Okay, good evening and good afternoon, everybody. Welcome to our session today from Thrombosis Canada. We are presenting the highlights from the International Society of Thrombosis and Hemostasis 2021 Virtual Congress, a Canadian perspective, and we have some great speakers this evening with some really important studies that will be presented. My name is Lena Castellucci, and I'd like to tell you about our program objectives this evening. So we will provide our Canadian healthcare colleagues highlights of the key hematology related presentations from the ISTH 2021 Congress and deliver an opportunity for discussion on the latest developments in hematology. We offer an opportunity for our healthcare colleagues to engage with hematology experts from across the country. And in order for you to participate actively, we'd like to invite you to ask your questions in the chat function. We will hold questions until the end of the presentations, but please add your questions throughout the talks so that we can keep track of them and answer them. As I mentioned, my name is Lena Castellucci, and I am a thrombosis specialist and general internist at the University of Ottawa. I'm a researcher, and my area of interest in research is thrombosis and anticoagulation safety. In addition to myself, we have Dr. Gregoire Legal, who is also a thrombosis expert and general internist with me here in Ottawa, and he is the director of the thrombosis program in the Division of Hematology. He's a senior scientist at the Ottawa Hospital Research Institute, and his research program is very active in the diagnosis and management of venous thromboembolism. We will be discussing the thrombosis aspect of this evening's presentation. And to add to that, we have our colleagues in the hemostasis side, and I'd like to introduce Dr. Mark Bellatrudy, who is a pediatric hematologist and medical director of the Pediatric Bleeding Disorders Program at the BC Children's Hospital in Vancouver. And he recently transitioned there from the Stollery Children's Hospital in Edmonton. His academic interests include medical education and research related to bleeding disorders in the pediatric clinical trials realm. And our fourth speaker this evening is Professor Alfonso Iorio from McMaster University, and he is chair from the Department of Health Research Methods, Evidence, and Impact, and director of the Health Information Research Unit. Professor Iorio has a very active research program in hemostasis and specifically hemophilia. And outside of that, he's very active in methodology related to systematic reviews and meta-analyses. So it's my pleasure to be speaking with my colleagues this evening. These are the disclosures for each of us that are relevant for this evening's presentation. So I'll give you a moment to read through our disclosures. Okay. And I do need to disclose our commercial support. So our program this evening did receive funds from BMS Pfizer Alliance in the form of an unrestricted educational grant. The potential for conflicts of interest, of course, with that is that we as speakers are eligible for honorarium from Thrombosis Canada, and the BMS Pfizer Alliance may benefit from the sale of products that may be discussed in the program this evening. To mitigate potential bias, the content of our program was developed by the faculty and peer-reviewed by Thrombosis Canada. Recommendations involving clinical medicine are based on evidence that is accepted within the profession, and all scientific research referred to, reported, or used in the program in support or justification of patient care recommendations conforms to the generally accepted standards. Our program this evening is accredited, and it's an accredited group learning activity under Section 1 as defined by the Maintenance of Certification Program of Royal College of Physicians and Surgeons of Canada, and it is approved by the University of Ottawa's Office of Continuing Professional Development. You can claim up to 1.5 hours maximum, and the credits are automatically calculated for you. In order to achieve your credits at the end of the program, there will be a link in the chat function for an evaluation, and once the evaluation is completed, you can claim your credits. As a reminder, throughout the presentations, please use the chat function to ask any questions that you have, and we will aim to address them at the end of all the presentations this evening. So I am going to begin our presentation tonight, and the objectives for my portion are to review and discuss two different important studies that were presented at the ISTH Virtual Congress. The first is related to symptomatic distal deep vein thrombosis and use of rivaroxaban for the treatment of symptomatic isolated distal deep vein thrombosis, or the Ritz Study. And we'll also review diagnosis of pulmonary embolism in pregnant women, looking at the oral abstract that was called Assessing the Clinical Probability of Pulmonary Embolism During Pregnancy, the Pregnancy Adapted Geneva Score. So the first study that I'll talk about is the Ritz study, and this was presented at the Congress by Dr. Regino from Italy. I apologize, it's cut off a little bit, but at the bottom, this study is now available in preprint form, as much of the literature these days is now available in preprint. So as a reminder, preprint means that it has not yet undergone peer review. However, in my review of this, the information is very similar to what was presented at the Congress, and I will be presenting the information from the preprint. So the background for this study, as we know, isolated distal deep vein thrombosis is common, and I'm going to refer to this moving forward throughout the presentation simply as distal DVT. And it is seen in about 30 to 50% of all deep vein thromboses. And if left untreated, the rate of extension to a proximal DVT or even embolization is about 20 to 30%. The 2012 CHEST guidelines recommended conservative management for most patients, but they did suggest treating a certain group of patients that were considered high risk of extension and those with severe symptoms. High-risk patients were patients who had malignancy, those where the distal clot was quite close to the popliteal vein and risk of extension was deemed to be higher, patients who had a positive D-dimer or who were immobilized, for example, that would be considered a high-risk patient group. What's still prevalent today is that there is lack of standardized treatment approach for distal DVT. The conservative approach of using serial ultrasound for a couple of weeks as well as anti-inflammatories is still quite common. And then there's another group where anticoagulation may be used with the same dosing regimen as for proximal DVT and pulmonary embolism. And if anticoagulation is used, it's often used for a shorter duration, such as 4 to 6 weeks, but we don't really know whether or not that is appropriate. And so the purpose of the Ritz study was to compare the efficacy and safety of two different durations of treatment with rivaroxaban in patients with symptomatic distal DVT. And the goal was to assess the long-term risk of recurrent VTE up to 24 months. And in this presentation, I will present data up to 6 months of follow-up. So this is a little bit of a busy slide, but it does describe the study design. It was a double-blind, placebo-controlled, multi-center RCT in 28 Italian centers. And adult patients with symptomatic confirmed distal DVT were eligible for the study. And all participants received standard dose rivaroxaban, 15 milligrams twice a day for 21 days, followed by 20 milligrams daily for 21 days, for a total of 6 weeks of treatment. And it was at the 6-week mark that patients were randomized to receive either ongoing rivaroxaban 20 milligrams daily for another 6 weeks or placebo. The exclusion criteria are listed here. So patients who had active malignancy, pregnant or lactating women, any evidence of pulmonary embolism or proximal DVT, creatinine clearance less than 30, or high-risk liver disease, such as you couldn't use rivaroxaban safely, other reasons for oral anticoagulation long-term, and if patients had received more than 72 hours of anticoagulation, they were also ineligible. Patients were followed for up to 24 months, and this is the follow-up schedule. So they were followed at 3 weeks, 6 weeks, 12 weeks. And at the 6 weeks and 12 weeks marks, they had serial bilateral leg ultrasounds. And this was regardless of symptoms. And then later on, they had follow-up at 6, 9, 12, 18, and 24 months. In the bottom box here, I've listed what the outcomes were for the trial, and the primary efficacy outcome is a composite, which included progression of the distal DVT to the proximal veins, recurrent proximal or distal DVT, symptomatic pulmonary embolism or fatal PE, and the primary safety outcome was major bleeding, defined by the ISTH definition that we all know. Secondary outcomes included each component of the composite, as well as clinically relevant non-major bleeding. And they also looked for arterial events, so including ACS, stroke, TIA, and peripheral arterial disease that was acute. So the hypothesis that this group had was that a longer duration of rivaroxaban of 12 weeks would be superior to 6 weeks of rivaroxaban, and it was meant to be an intention to treat analysis. Initially, they had planned to recruit 1,100 participants to show a 50% reduction in the primary efficacy outcome at 2 years, from 8% to 5%. Unfortunately, the study was stopped early due to slow recruitment, and this decision was made at a second predefined interim DSMB analysis, and only 30% of participants had been enrolled at that time. So we have information for a total of 402 participants. So initially, through this flow chart, you can see 448 patients were enrolled, and then 46 of them were not randomized for various reasons. Some of the adverse events that occurred are related to recurrent thrombotic events that happened in that initial 6-week period, as well as 3 major bleeding events during that initial 6-week period. 402 patients were randomized, and 200 received rivaroxaban 20 milligrams once daily, and the remaining 202 received placebo. A few patients were lost to follow-up, and those that completed 6 months of follow-up are listed at the bottom. So with respect to baseline characteristics for each of the patient groups, they're listed here. The majority of patients in each group were women, approximately 60%, and they were about 65 years for their mean age. It's interesting how they report the location of the clot. So the axial veins are considered the anterior and posterior tibial veins, and the muscular veins are the gastrocs and soleus muscle veins. And the majority of the clots were, in fact, the muscular veins, so about 65% in each group. The risk factors are listed here. So approximately 40% in each group had unprovoked distal DVT, and the highlights are listed here for surgery, trauma, and immobility related. Many of these patients had prior history of VTE, and about 25 to 30% had symptoms that were present for longer than 5 days prior to presentation. In terms of those that received anticoagulation before enrollment in the study, it was up to 40% in each group, and the anticoagulants used included low molecular weight heparin, fondaparinux, and rivaroxaban. These are the outcomes, which are VTE, recurrent VTE outcomes at 6 months. And what you can see is they report this as total VTE events. So for the rivaroxaban group, there were 5 events, and in the placebo group, much higher at 21. And that was a significant difference with the p-value of 0.001. They broke this down according to when the events occurred. So during treatment, during that initial 12 weeks of therapy, 3 events occurred compared to 15 in the placebo group. And then during the remaining 6 months of follow-up, 2 and 6 respectively. They did report this importantly as symptomatic and asymptomatic events, because as you recall, they did bilateral leg ultrasounds at weeks 6 and 12. And there were a significant number of symptomatic events in the placebo group, so about 8% compared to 1.5% in the rivaroxaban group. With respect to where the events occurred, so the majority of them in the placebo group were distal events, and you can see that proximal events were not statistically significantly different between the 2 groups, but there was that difference in the distal DVT between the 2 groups. So much more common to have recurrent distal DVT in the placebo group. They also looked at where the recurrence occurred. So when patients had repeat ultrasound imaging, they had specific criteria to determine if the extension or recurrence was within the same vein as the index DVT or if it was in a different location. And you can see here that, again, they report this according to whether or not patients were symptomatic at the time of recurrent VTE diagnosis. One patient in the rivaroxaban group had a proximal DVT and one had a pulmonary embolism. Similarly, in the placebo group, one patient had PE and 4 patients had proximal DVT. Next, we'll move on to a pre-specified subgroup analysis. So they looked at the different distal DVT locations, whether or not the events were provoked, and importantly, they looked at difference in the sex of the patients. And what they found was that this was really the only group where there was a difference. So female patients were more likely to recur in the placebo arm, but male patients were not. They had equal recurrent event rates, which is an interesting finding because, as we know, men with unprovoked VTE, that's proximal or pulmonary embolism, are typically felt to have higher rates of recurrence. So this was an interesting finding. Next, we'll move on to the safety findings with bleeding events. So during the initial 6 weeks of treatment, which was pre-randomization and open label with everybody being on standard dosing of rivaroxaban, there were 3 major bleeding events and 15 clinically relevant non-major bleeding events. And then post-randomization, there were no major bleeding events in either group, which is an important feature when we consider safety of extending anticoagulation therapy. Clinically relevant non-major bleeding occurred equally with 1 event in both groups. So again, very reassuring. So in summary for the Ritz study, what we found was that 12 weeks of rivaroxaban significantly reduced the incidence of the primary outcome of recurrent VTE at 6 months compared to shorter duration of 6 weeks. And the benefit was seen in all subgroups except for the male sex. The incidence of proximal DVT and pulmonary embolism was similar in both groups, and really the greatest benefit was seen in reducing the rates of recurrent distal DVT. There was no increased bleeding, either major bleeding or clinically relevant non-major bleeding with the longer duration treatment. And so, of course, we need to consider what is our next step and how will we use this information when we see patients with distal DVT. Will we treat our patients with standard dose anticoagulation for 12 weeks? And we can discuss that in the question and answer period. Next, I'm going to move on to my second presentation for the evening, and this is a really interesting study that highlights an area of important diagnostic needs. So this is assessing the clinical probability of pulmonary embolism during pregnancy, the Pregnancy Adapted Geneva Score, and Dr. Helia Robert-Ebadi presented this, and it was featured in the ISTH highlights as well. So as we all know, diagnosis of PE in pregnancy is challenging, and a lot of this has to do with the overlap of clinical presentation, where symptoms of PE can also be found in normal physiologic pregnancy, including dyspnea and tachycardia. There's also a fear from a physician perspective about missing the diagnosis of PE, as it could be potentially fatal. And because of that, it does lower our threshold to suspect pulmonary embolism in pregnant women. And unfortunately, what that leads to is a lower prevalence of confirmed PE in suspected patients. We know that the diagnosis of PE in pregnancy does not have any validated algorithm. So traditionally, we use standardized diagnostic management algorithms to reduce unnecessary chest imaging, but unfortunately, we don't have any of these clinical prediction rules that have been developed and validated in pregnant women. And so what we really want to do is determine their pretest probability to select patients for non-invasive exclusion of PE with using a negative D-dimer test. But because of the limitations in pregnant women, including reluctance to use D-dimer because it can be elevated in all stages of pregnancy, and it can be even higher as pregnancy progresses towards term delivery. And there's also the important need to reduce our risk of radiation exposure during pregnancy for both the woman and the fetus. There are 2 prospective management cohort outcome studies that have been performed. The first is the CTPE pregnancy study that used the revised Geneva score, and this was published in 2018 in the Annals, and it was led by Dr. Legal. So it's great that we have him here this evening if there are any questions that he can assist to answer. And then the second is the pregnancy adapted years study, or the Artemis study, that was published in the New England in 2019. For this particular study, what the group did was they used the CTPE pregnancy study to propose a clinical probability prediction score adapted to pregnant women with suspected PE. And on the right-hand side, you'll see the eligibility criteria for that study. So of course, it was pregnant women with suspected PE, and it was defined by acute onset of new or worsening shortness of breath or chest pain that couldn't be explained with any other cause. And the exclusion criteria are the standard ones, so allergy to contrast, renal failure, PE diagnosis prior to presentation, and already on therapeutic anticoagulation or an alternative indication for it. This study was conducted in community hospitals and academic hospitals in Switzerland and France, and it went on for about 9 years. 395 participants were included, and 28 were diagnosed with PE, giving a prevalence of about 7%. So this is the schema on the left-hand side that was used for determining pretest probability in women with suspected PE. They had a pretest probability assessment using the revised Geneva score, and depending on whether they were high risk or low, they underwent the algorithm that's listed here. So this is the revised Geneva score that I've shown here, and when one tries to develop a clinical prediction rule, you need to have a certain number of events in order to do the formal approach with using multivariable logistic regression. Unfortunately, there aren't enough outcome events. There were only 28 events to do this formally. And so what this group decided to do instead was take a different approach and modify the Geneva score and adapt it to a pregnancy population. And so they looked at what are the variables in the revised Geneva score that are relevant to the pregnant population and which ones are not. So when they looked at their cohort of 395 patients, of course, none of them were older than 65, and none of them had an active malignancy. And so these 2 variables were removed. There was some missing data for 5 patients. The heart rate variable was missing, and for the other 7 remaining items, there was no missing data. Now, the age and heart rate are continuous variables, and so what the group did was try to determine what would be the optimal threshold for age, because we know that pregnancy doesn't happen in people older than 65. And because there was missing data for the heart rate, they wanted to find a different threshold for heart rate in this population. The patients that were included in this study are shown here, and most of the patients presented in their 2nd or 3rd trimester. They were about 30 years old was the median age. And down here, we've highlighted the symptoms that they presented with. So chest pain, dyspnea, syncope, hemoptysis, and clinical signs or symptoms of deep vein thrombosis are all listed there. And so those are the important things that would have made them eligible for the study. Now, when we go back to how they developed the score, I mentioned that they use the ROC analysis, and the reason for doing that again was to try to evaluate the age and come up with a threshold that would be more discriminate than older than 65. And when they did this, they found that being 40 or older was an important threshold. And similarly, when they looked at heart rate, they found that above 110 beats per minute was a good threshold for this. So this became the pregnancy adapted Geneva score. So the cancer variable was removed, and then the other items remain the same, with the exception of a change in the age threshold and the heart rate threshold. The next thing that they did was, in the population of 395 patients, is they wanted to develop a 3-level score. And so what they did was assign a score to the participants in the study. And when they did this, of course, they were looking for a low prevalence of PE of less than 10% to categorize as a low pretest probability, and to be considered high pretest probability, the prevalence of PE would be above 50%, and intermediate would be in between that of 10 to 50%. So when you look at pretest probabilities, a score of 0 to 1 categorized you as low, 2 to 6 was the intermediate group, and 7 or higher was the high pretest probability group. So what that looked like when they calculated the distribution of patients in each category of low, intermediate, or high, the majority of patients were in the low group, which is what we expect to find, so nearly 70%. And that corresponded to a prevalence of PE of about 2.3%. And as the risk increased, what you saw was that the prevalence of pulmonary embolism also increased. So the intermediate group was about 30%, with a prevalence of nearly 12% for PE, and 3% of the population was found to be high risk pretest probability, with a prevalence of 60% for pulmonary embolism. So what I'm showing here on the left-hand side is the revised Geneva score that was used in the original CTPE study. And then on the right-hand side is the pregnancy-adapted Geneva score. They wanted to assess how good these scores were. And so they again did ROC analysis and determined the area under the curve. And what you see here is that the area under the curve for the pregnancy-adapted Geneva score is quite good at 0.8. And so this is a very reassuring model that could potentially be used in place of the revised Geneva score. Now, of course, there are limitations to this methodology. So as I mentioned, there were not enough events to traditionally determine a clinical prediction rule based on our formal multivariable logistic regression. And so we used the information that we had, and we did a modified Geneva score to apply it to the pregnant population. It's also challenging to conduct trials in the pregnant population for a lot of reasons, including low prevalence of PE in pregnant women with suspected PE limits the number of positive diagnoses for derivation analyses. And what's important to conclude from this study is that for pregnant women with suspected PE, we don't have a validated clinical prediction rule available. But what the pregnancy-adapted Geneva score provides are variables that are clinically relevant to this pregnant population. And we saw that it had good discriminatory power to categorize pregnant women in the 3 categories of low, intermediate, and high pretest probability, which corresponded with increasing PE prevalences. And so I'm going to suggest that in agreement with the group performing this study, is that we really need to evaluate this this new scoring system in a prospective outcome study and see how it fares in that prospective cohort. And so I will stop there, and we're not going to take questions just yet, but I will pass over to my colleague, Dr. Legal.
Thank you, Dana. Hi, everyone. I hope everything works well. So I will go quickly over 2 studies that I selected for tonight. The first one is the one that I actually presented at the meeting, which is a study that we led with Dr. Marc Carrier from Ottawa. And that's about the management of subsegmental PE without anticoagulation. So very quickly to say that we've seen, after starting to use CTPAs, an increase in the rate of PE without an overall decrease in mortality, suggesting that we are likely diagnosing a bit too many PEs these days, and that treating them all, treating the smallest one, might not be relevant. And a few years back, the ACCP started to discuss that maybe in some patients, very selected, very cautious recommendation that some of them might not require anticoagulation, which is what we wanted to test and to see if those at low risk of recurrent VTE who wouldn't have DVT on bilateral ultrasound and who would not be receiving anticoagulation would have a low enough rate of recurrence events. So we included patients with isolated subsegmental PE, meaning pulmonary embolism that would not be more proximal than subsegmental, so no segmental, no lobar, and so on. And we excluded the ones that were felt to be higher risk of recurrent events, such as cancer patients, patients with a previous VTE, patients who were hypoxic, pregnant women, or those who had an indication for long-term anticoagulant therapy. So what we did is that they all had a bilateral leg ultrasound on the day of inclusion. The ones with the proximal DVT were obviously excluded and were receiving anticoagulant therapy. The other ones were left untreated, all came back for a serial ultrasound 1 week later, and the one who again didn't have a DVT on that serial ultrasound remained untreated for the remainder of the follow-up period. Primary outcome was a rate of recurrent VTE during follow-up. Secondary outcomes included bleeding, major or minor, everything adjudicated centrally. So what we wanted to show was that the risk of recurrent VTE would be no higher than in those patients that come in with a suspected PE, have a negative CTPA, and are left untreated because they don't have a PE. And usually it's okay to rule out PE with a strategy whose 3 months risk of VTE would be no higher than 3%. So that's what we used there. Initially, when starting the study, obviously there were major concerns about the potential risk of recurrent VTE. So we had a stopping rule in place so that as soon as we would know that the recurrence rate would be for sure higher than 5%, the upper limit of the confidence interval at the end of the study, we would discontinue the inclusions. And that was actually reached very short of our 300 planned patients. We reached that limit after including 292 patients. So here is a study flow chart. I will go quickly on that, but just to say that some patients did have anticoagulation initiated because they were diagnosed with a DVT. A few were either lost to follow-up or withdrew consent, so that the final analysis is of 266 patients. These are the characteristics of the population, nothing really remarkable. They were symptomatic patients, obviously, chest pain, shortness of breath, and the majority of them had a single subsegmental PE, but we had a significant proportion of patients with multiple subsegmental PE. Primary outcome rate, as I told you, we did stop the study because of a higher than anticipated thrombotic rate, and overall the cumulative incidence of recurrent VTE was 3.1%, with a 95% confidence interval ranging from 1.6 to 6.1. Just a bit of breakdown of the recurrent events. We also did have some bleedings, including 2 major bleedings in patients who were not on antithrombotic therapy. And we know from other studies that patients who are not on anticoagulants also do have some major bleeds, definitely. And we had 4 deaths, but none of them related to thrombotic events. We had also planned some subgroup analysis, mostly based on whether the PE was a subsegmental, only one single subsegmental or multiple. And as you can see, there seems to be a difference in the risk of recurrent VTE, even though that wasn't statistically significant. And in a similar way, age seems to have an impact as well, with patients younger than 65 having a 1.8% risk of recurrence, whereas the ones 65 or older had a 5.5 risk of recurrent VTE. Some limitation to that study, so the risk is a bit too high, and we had patients who were not the high-risk ones. We didn't have patients with cancer or previous VTE. Potential limitation as well is that we wanted it to be pragmatic, so we accepted the diagnosis of subsegmental PE as it was made in the participating centers, but we plan to do some analysis on centralized reading later on. And we did not have follow-up beyond 3 months, so we couldn't answer the question of long-term risk of recurrent VTE or CTEPH. So to conclude, it appears that patients with isolated subsegmental PE who do not have a DVT have a higher than expected rate of recurrent VTE, and that should certainly be a consideration in managing these patients. I will jump right away to the second study that I wanted to highlight, and that one was a cohort study comparing bleeding risk scores in cancer patients. So that was interesting because we know that despite new advances in the treatment of cancer-associated thrombosis, a lot of patients have bleeding, 4% in clinical trials, even higher rates in quote unquote real world studies. And these have a high morbidity in terms of ICU admission or interruption of cancer therapy. So the authors looked at some of the mostly used clinical decision rule for bleeding. You can see hemorrhage, VTE bleed, ACCP, and so on. But they were doing the rationale that many of these have limitations, particularly for cancer patients, right? Most of them were developed in a vitamin K antagonist population. Some predictors are much more prevalent in cancer patients. Some of these core actually have cancer as one of their predictor. So obviously that doesn't apply to a cancer population. Anemia might be so variables in terms of origin and significance in cancer patients as well. They couldn't include some cancer-specific predictors, so we don't have in these scores anything about tumor type or thrombocytopenia or anything like that. And it was known from previous studies that the VTE bleed score, for example, is not good in cancer patients. So what they did is that they took a cohort of veterans with active cancers in the United States between 2012 and 2018. And after excluding those who were already anticoagulated for a prior VTE or those who did not receive anticoagulation following the VTE diagnosis, they ended having close to 7,000 patients with cancer-associated thrombosis and used as a primary outcome the risk of major bleeding with these ones. This is a comparison of the bleeders with the non-bleeders. And you can see the usual suspects here: patient with anemia or patient with renal failure or a patient with a previous bleed being at higher risk of getting a bleed on anticoagulants. And then they looked at these three scores: the has bled, the VTE bleed, the hemorrhage, and they looked at the C statistics, the area under the curves that Dr. Castellucci was showing earlier for the clinical decision rule. And as you can see here, overall, it's not really good. Like the C statistics, the area under the curve was below 0.6 for each of these three scores. And these hazard ratio give by how much the probability of bleeding increased for each additional point in the score. So there was a slight increase. The increase was significant. So there is a correlation between the number of points and the risk of bleeding. But again, the overall accuracy was not really good. And I thought that was interesting as well. What they show here on the right side were curves showing how the area under the curve would evolve according to time, and which was kind of neat because indeed you can see that maybe the ability of a score to predict bleeding might be different as time goes by, and that might actually be partially true for cancer patients because a lot of things happen to them during the course of their treatment. But they didn't really show that, and the curves were pretty flat, I would say, with no significant changes over time of the predictive accuracy of these clinical decision rules. So they concluded that the scoring system only modestly predict major bleeding in patients with cancer-associated thrombosis receiving anticoagulant therapy, and that we likely need a specific model developed in patients getting modern anticoagulant therapy and really predicting these bleeds in these cancer patients. Thank you for your attention, and I will be happy to take questions at the end of the other presentation as well.
Okay, good evening, everyone. I'm going to switch gears here and move into more of the hemostasis. So pleased to join you tonight and share some of the presentations at ISTH that were related to hemophilia and other hemostatic disorders. So my plan tonight in my section is to review some of the data on joint health of adolescents, using data from the Pednet cohort, which I'll explain when I get to the abstract, and appraise the objective measures of how they analyze joint health in these patients. And then the second abstract is a nice study looking at the real world pharmacokinetics of one of the new hemophilia treatments. I'm going to refer to it as JIVI, which is the trade name, and this is one of the extended half-life factor VIII products. So looking at the Pednet study first, this study was looking at long-term outcomes in adolescents with moderate or severe hemophilia. And really their question, and me as a pediatric specialist, was what kind of joints are we giving to our adult colleagues when we graduate our pediatric hemophilia patients? And that's one of the things we try and implore and try and get good joint health before we transition our patients to more adult care. And previous studies have shown that upwards of between 20 and 50% of pediatric hemophilia patients actually already have signs of joint deterioration by adolescents, despite early or primary prophylaxis. So this cohort was from the larger Pednet cohort, and this is a consortium of hemophilia centers, primarily based in Europe, but with some US and Canadian sites who contribute data as well on their hemophilia patients, including treatment data, adverse events, joint bleeds, and joint health. So this was a subset of that cohort that looked at 5 centers who used a structured joint assessment protocol. And those centers are listed here. And they looked at, their primary objective was to see how the hemophilia joint health score 2.1 performed in their adolescents and whether they were detecting early signs of joint issues. And then the secondary objective was to look at early arthropathy detection with ultrasound, which may not yet manifest itself clinically in these patients. And they wanted to compare their severe hemophilia cohorts with a smaller subset of moderate hemophilia patients, as well as those severe hemophilia patients who had inhibitors, comparing them to the group that did not have inhibitors, to see if there were differences in both of these objective measures of joint health. So this is the flowchart, and you can see that they were able to gather data on initially 226 patients, and then they excluded those who didn't have joint data, and were able to get that to 168. They excluded a further 24 patients. They wanted patients who had their hemophilia joint assessment done at over 10 years of age and hopefully closer to before turning 19. And then this was not looking at hemophilia B patients at this point. So we were left with 144 patients, which I know the previous studies were adult studies and you saw much larger numbers, but this is actually quite a big pediatric study comparatively. And we had, they had 100 patients without inhibitors with hemophilia A. The vast majority were severe patients with a smaller amount moderate, and this is pretty typical distribution for hemophilia. And then in their inhibitor patients, they had 41 severe patients with inhibitors. They did not analyze their 3 moderate patients and did not make any conclusions on that small number. So looking at their baseline data, no surprise, severe patients had no factor VIII activity. And for the most part, their median age at joint exam was around 15 in this cohort, with most of the severe patients starting their prophylaxis around the usual age, which is 1 to 2 years of age. Moderate patients, if they do go on prophylaxis, they tend to start later, and that certainly reflects usual practice that we saw in our cohort here. And the vast majority of severe patients, 98%, were on prophylaxis, which is the standard and has been the standard for severe hemophilia since the late 1990s. And most of them, as expected, started before 24 months of age, and then smaller percentages in the moderate patients, which again is reflective of usual practice. Of the 41 severe patients with inhibitors, 4 of them had persistent inhibitors at the time of analysis, most of them having been eradicated. So looking at the physical exam of joint health, which uses the standard HJHS scoring system, just a quick word about HJHS. most pediatric patients have a score under 4. The maximum is quite high. I think you can get up to 130, 140, which is quite severe. But most pediatric patients are usually under 4, and it's rare that they do climb above that, even in severe hemophilia. And what you can see here is that for the most part on physical exam, very few of the severe hemophilia patients, 9%, were classified as having abnormal gait on that part of the analysis. And then the cumulative score was pretty much negative, with a smaller percentage having a higher score over 4, which implies some early joint disease, but not enough to significantly raise the score. That was the same finding in the moderate patients, which you can see in the box plot here. The majority were under that 4 score with a few outliers. And the main difference here was that certainly if you have inhibitors, which in the era of these patients being treated for their inhibitors, it'd be expected to have more joint bleeding than non-inhibitor patients. There definitely was a difference with those patients having much higher joint scores on physical exam, indicating some joint damage. The picture was similar, but with some differences when they looked at ultrasound. So a number of patients had synovial changes, half of them detected on ultrasound. Similar findings in the inhibitor patients. Cartilage changes were a little bit higher in the inhibitor patients compared to the severe patients. Bone changes, again, were low, but higher in the severe hemophilia patients. And no surprise, they do have more joint damage. And then the cumulative score at the bottom. The moderate patients were maybe a bit better than the severe patients, but certainly there were some changes detected. So certainly higher percentages than what could be detected on physical exam, indicating the joint damage is happening despite good prophylaxis, and that physical exam on its own may not be something that can be relied on, and that you do have to include imaging on a regular basis in these patients. So they then wanted to look at if there was any concordance between the two. And overall, their concordance was reasonable, with patients who had high HJHS scores. A number of them had detectable damage already, and then smaller in normal. And then I think the other big thing is that a normal ultrasound should show that you have a normal HJHS. But certainly as you develop more damage, the ultrasound seems to be able to pick it up before you actually have a change in your joint score. And so this could be important in refining the treatment plan for these patients to allow them to continue to have only subclinical changes rather than having it early on to develop into clinical changes. And certainly the inhibitor patients were still the ones with the worst score compared to the non-inhibitor patients. So overall, in these adolescent patients, generally the joint outcomes were favorable, especially in those who received prophylaxis. There was more damage in the inhibitor patients. So certainly that's a group we have to be more on top of. Joint ultrasound seemed to detect more subclinical changes, which is important from a surveillance perspective and a ongoing physiotherapy perspective, as well as impetus to continue prophylaxis into adulthood, which for a large number of these boys tends to wane in their 20s. The combined assessment may provide better sensitivity, so doing the exam and the ultrasound, which is what a lot of the pediatric clinics are trying to incorporate more and more as we learn about these findings. And some moderate patients can have minor joint abnormalities like severe hemophilia A, which is not a new finding, but just reinforces that we do have to be very cautious with these patients and monitor them closely. Some of my thoughts is that this was only 5 of the centers, and the larger cohort should be examined. And this was one of the speculations from the presenters as well. This certainly justifies the need for ongoing regular physiotherapy assessment and ultrasound assessment when we do see these patients. And a number of clinics are struggling with physiotherapy. And so this is further impetus to ensure that those services continue. And then the wild card is non-factor therapies like emicizumab, which was recently approved in Canada, will likely change things further, but there will still be a lag of a number of patients who are currently graduating before they switch to this medication. So we do have to continue to follow their joint health closely to ensure that they have good functioning joints for as long as possible as they age into the adult ages. So quickly, I'll move on to the second study, which was real-world use of demoxicog alpha-pegol, also known as GIVI, in patients with hemophilia A. And this was analysis of their pharmacokinetic profiles and treatment regimen data from the WAPS-HEMO database. So this was an analysis of 176 pharmacokinetic studies with this medication from 52 hemophilia treatment centers worldwide. And the aims of their study was to describe the pharmacokinetic estimates obtained in a real-world setting and to model the proportion of patients able to achieve predefined factor VIII trough levels according to different treatment regimens. So the variables were extracted from the WAPS-HEMO database, which is a worldwide database that treatment centers can input their patient data and treatment regimen and factor data in there, and using a population pharmacokinetic model provides PK estimates to the centers. And so all this data was extracted for the patients who had GIVI patients who had their information inputted into the database. And then the second part of their study was to actually do a modeling exercise using this data to see which proportion of patients achieving target trough levels of interest, which I'll explain later, could get there with commonly used treatment regimens. So there was, I mentioned, 176 studies. 160 of these studies were in severe hemophilia A patients, 15 in moderate and 1 in mild. Most were adult patients, although there was a cohort of adolescent patients, fairly wide body weight distribution. I averaged dose of 35.6 units per kilo, which is fairly standard from a prophylaxis perspective, and a range of dosing intervals from 1 to 7 days with this dosing, with a median of 3.5 days or twice a week, which is a fairly standard regimen using this hemophilia product. So 84 patients had information on their current treatment regimen, and of those 84 patients, half were on twice weekly. There was and then a smaller subsets on either every 5 days or every 7 days, which are also possible treatment regimens for this type of medication. So first thing they looked at was comparing the PK estimates from their patient population compared to what was done in the phase 1 study for this medication that used a small subset of patients, but had a fairly dense sampling, whereas more sparse sampling PK estimates in the WAPS database can be done with as little as 2 to 3 sampling points. Really fairly comparable terminal half-life, volume of distribution, and clearance of the hemophilia product. So showing that even with in a real-world setting, still achieving fairly similar results to the original PK study for this hemophilia product. And then the second part was to look at the modeling exercises, where what can we achieve using targets of a 1% trough level before you do your next treatment, 3% or 5%, understanding that higher trough levels may confer more protection and reduce the chance of bleeding before the next dose is given. And so no surprise, with the lower threshold, a higher percent were able to achieve that target. But interestingly, even with using a fairly standard or even lower dose of under 30 units per kilo, 40% of the patients were still able to achieve this if they wanted a 5% trough using twice a week, which is certainly gives a nice balance from a balance between only treating twice a week and using a fairly low amount of product. So there's some a nice balance there of minimal treatment as well as the lowest dose possible, which allows allows for cost savings to the system for the hemophilia community and for the respective countries. And then even at a 3% level, a large majority of patients were still able to could achieve targets using a twice-a-week regimen, and even a higher number using every 5 days. And so really this showed that there was favorable PK profile for Jivi using a real world data. 40% of patients treated twice weekly at a median dose of 28 units per kilo could still maintain a fairly high trough level, and 5% is quite high in severe hemophilia. There was an additional poster with similar modeling that showed, compared this to the 2 other available extended half-life factor VIII products, and actually showed that factor VIII consumption can be conserved better with this product for a 3% trough and twice weekly dosing compared to the other 2 products, indicating that there may be some larger economic benefits as well to using Jivi over the other ones. And so what does this mean for us as hemophilia physicians and for talking to our patients? First of all, I think it encourages PK assessment, which a lot of patients can be reluctant to do, but I think this allows more data to show that we can really tailor their treatment and maybe make it better for them. It's another assessment tool in addition to bleeding pattern and frequency that we can use for a broader discussion, and really can enhance our treatment planning for day-to-day life, for the patient's activity level, and allows us really additional tools that can really tailor our patient's treatment and individualize it to really make things better for them, balancing out treatment frequency, having to do IVs frequently, having to give a lot of product. This really allows us to refine it even more, and hopefully allows for continued good protection of our patients. So those are the 2 studies I wanted to present, and I'll turn it over to our last speaker.
And thanks to Thrombosis Canada for kind invitation. Let me get set up for sharing. Okay. Okay, so my objectives for this night will be to review a new ways of prolonging half-life of factor VIII, which has a very nice and convenient add-on benefit of providing treatment for von Willebrand type 2B. This is not yet phase 3, but is very interesting, and one of the newest presentation was a late-breaking abstract, and also to review some lab evidence, laboratory evidence on, again, use of one of the currently available long-acting concentrate on the Canadian market. This is a slide from Mike Macri's State of the Art. I will focus mostly on long-acting, as I told you, so use of current long-acting or new ways of prolonging half-life. I wanted this slide to make sure I had a chance of telling you that there was not a lot of novelty around gene therapy. I was hesitant to skip gene therapy completely, but the gene therapy workshop this morning at WFH reviewed the same data from ISTH, and again, there's not a lot of novelty there. So let's delve into these new way of prolonging factor VIII half-life, the BT200 binding aptamer. This is a study that was presented as late breaking, and is work done mostly at the research group in Vienna, with participation from BAN Therapeutics, that is part of Guardian Therapeutics. I was involved in this study, but only providing PK estimates, so I have no stake with this specific product. What BT200 is a third generation von Willebrand A1 domain binding aptamer. Has a long human half-life, about 1 to 2 weeks, and it has a very good subcutaneous bioavailability. So can essentially be given sub-Q, for sure once a week, very likely on a less frequent administration frequency. And there is a reversal agent that has been successfully tested in animals. So in case these would be a concern in clinical use, it's already known that can be reversed. So what does this molecule do when administered in a human being? Essentially produce a sustained increase in the von Willebrand factor levels in healthy subject. Does not increase propeptide levels, which means does not affect the production of von Willebrand. The propeptide, the marker of production stays the same, while the level of circulating acting von Willebrand goes up. And it also reduces, how does BT200 obtain this increase in von Willebrand factor circulating levels? By reducing the clearance. And the mechanism is known, is through inhibiting macrophage removal of von Willebrand factor. So the study that was presented was a loading dose, a split loading dose of 3 milligram of BT200 for 3 days in the first week, and then a titration with a variable dose between 2 and 9 milligram weekly for a month. The study enrolled 10 non-severe hemophilia patients and 9 severe hemophilia patients. 8 of the patients received the full month's course. 1 stopped earlier at the time of presentation. So this is the main, this slide shows the main result from the study. Again, up here, you see essentially the frequency of administration, 3 doses to load, week 1, and then a weekly administration for a month, but then the patient were followed for longer. And if you focus on the antigen, so the black square, the antigen went up to about 3 times the baseline level, while the aristocytic cofactor stayed around normal values. I'll skip over the other markers of von Willebrand factor. Those were discussed in detail, but the bottom line is there is an increase of the antigen, which is what matters for carrying around factor 8. And indeed, this is what happened to factor 8 in this patient. You see in red the half-life on the left-hand side with the clotting stage, and on the right-hand side with the chromogenic assay, still half-life. And you see patient, the individual severe patient on the x-axis. So in red, you show the half-life before, and in green, the half-life on the BT200. And you see that with the exclusion of this last patient here, where there was a minimal increase, both with the clotting or the chromogenic assay, for most of the other patients, there was a significant increase of their half-life after co-administering, of course, factor 8 as per standard prophylaxis and BT200 once a week. These half-life were measured after a test dose administration on factor 8. And you see up here that these patients were treated with different molecules, the one they were treated on, and they continued their treatment regimen while they were receiving the BT200. If we look at this data on a tabular format, and we focus initially on the one-stage clotting, the mean increase in half-life was about 3 times. This is higher than we are used to see with extended half-life factor 8, where we know is about 1.5. So is approximately twice as long, and is a kind of prolongation we are seeing with another molecule that is currently being tested that decouple factor VIII and von Willebrand. So the mean is about 3, the median is 2.7. All the individual patients got an increase. The lowest one was 1.8. And if you look, for example, B domain deleted, the average increase was over 2, between 2 and 4.5. If you look at other wild type factor VIII, again, between 2 and 3. But even compared to long-acting factor VIII, like Elocta, significant increase again. Albumin fusion, again. The beauty of this approach is that you can get an increase of whatever factor VIII the patient is receiving by decoupling it from von Willebrand factor, which we know is a limiting step in the half-life of this patient. So, of course, it's a small study because of hemophilia, is a short observation period, and maybe the titration phase was not long enough to achieve steady state. So the result might be better in the long term. The strength is that is a sub-Q treatment that can be added to any existing and available factor VIII and can be used irrespectively of severity, irrespectively of the specific factor VIII the patient is on treatment on. And the effect is larger than any other currently marketed extended half-life factor VIII. Now, safety-wise, there were no signal, but it's a very small population. From the conceptual viewpoint, is the first approach that produce increase half-life of endogenous factor VIII. So if you give a BT200 to mild patient, you will obtain an increase in the half-life of their own endogenous factor VIII. Without giving any extra factor VIII, their level will go up. The conclusion corroborated by the discussion were that this is certainly worth studying in a phase 2-3 trial. To complement this result, there was an oral presentation by the same group about what this may mean for von Willebrand disease type 2B. I won't waste time on characterizing too deeply what von Willebrand type 2 is and specifically what type 2B is, but I want to mention two aspects of type 2B. Type 2B is a qualitative defect of von Willebrand where there is a gain on function. Von Willebrand is more avid to bind platelets, so this patient bleed particularly badly because not only their von Willebrand is dysfunctional, but the von Willebrand takes down their platelet count. So they have two reasons now to bleed, a defective von Willebrand and a decreased platelet count. And this also diminishes the capacity of treating this patient with DDAVP. So essentially, this category of patient is treated with von Willebrand replacement therapy. Now, the hypothesis here is that sub-Q administration of BT200 could not only increase the von Willebrand factor level, like shown with previous aptamers in animal models, but also decrease the binding of von Willebrand to platelets and improve the platelet count. This is a very small study. Von Willebrand type 2B is very rare, but 5 patients were treated. And I'd like to point out to you here that 4 of these 5 patients had low platelets at start and had decreased von Willebrand antigen. Their factor VIII, as expected, was normal with exclusion of 1 case. Now, we may expect the von Willebrand factor to go up for the same reason we discussed in the previous study. BT200 decreased the clearance of von Willebrand, and this happened. But what was actually shown is that there is an increase in platelet count. So again, in blue, the count before, and in purple, the count after the administration of the BT200 aptamer. And you see that in most patients, there was a minimal or very significant increase in platelet count that was sustained over time. And these platelets were also functional. These patients have a decreased aggregability of platelets, and over time, even if the variability remained very wide, they achieved close to the normal range of platelet aggregation. This is a very exciting time for von Willebrand type 2B patient in that this treatment, if proven to be safe and effective, will be the first one that can at the same time increase von Willebrand factor, increase factor VIII clotting activity with the same mechanism as in hemophilia, and reduce the negative effect on platelets. Of course, these need to be repeated on more patients, and of course, we hope to continue to see such great effect as we did. Okay, let's switch gear and come back from the future into the present. This is a study that was reported as interim result. It's a field study investigating the variability of, again, GV measurement using different lab reagent. I don't need to explain you what GV is. Mark did in the previous presentation. What a field study is a study where in 13 countries, over 150 laboratories received 5 samples and were invited to measure how much factor VIII was in those samples. And then central analysis compared the result with different reagents. The main results are on this table. This is a very busy table, but I will try to guide you to read what matters here. The driving hypothesis for this study was the demonstration during the registrational phase of GV study that there were a few clotting reagents not suitable for measuring this concentrate, APTTSP, for example, and STAGO-PTTA. If you look at the median recovery here in the last column, you see that indeed STAGO-PTTA recovers much less than one would expect. There was another reagent that was found to be associated with a very low recovery. And this means you cannot really use these 2 reagents. If your lab used this reagent for PTT or for factor VIII, you will not be able to measure a GV level in your patient plasma. Even APTTSP, which is a very common reagent in Canada, gave a suboptimal reading. The author defined normal, whatever reading was between 70 and 130, which is a standard way of considering acceptable reagents. But these are clearly values outside the range. What I'd like to show to you, though, and this was not really known formally before this study, is that all the reagents based on ellagic acid here, actin FS, again, FSL, these are very common in Canada. Syntafax is used in Canada. They give readings that are actually on the upper end of the normal range. And if you look at the variability, for all these reagents that were used in a significant number of centers, the readings are above the acceptable range, which means if you use this reagent, you will read level higher than real, which we know as treater is a dangerous situation because we interpret that our patients are well protected when they really are not, because the true value is lower. So while it was confirmed that 2 reagents read low, and these are, as I told you before, the PTTA and the Syntazil, there are 2 reagents that we would be careful around in Canada, the FS and the FSL, that may read higher than normal. This was not particularly stressed out during the presentation, but hopefully will be in the final report. Chromogenic assay, no big difference. There was no big finding, sorry, there was no chromogenic assay known not to be suitable for this concentrate. Trinichrome actually underperformed, again, reading below the normal values. That's the only one that consistently read lower. There is no one overestimating the concentration. In terms of variability, and this is my last bit of evidence I have to communicate, the field study allowed to evaluate the variability for the reagents that were used in a larger number of labs. And you see that it's significant. At best is around 15%, but more commonly is around 30%, which means we still have to accommodate that the reported value by the lab can be significantly higher or lower. And this is something we always need to take into account, particularly when measuring peak values. I also like to point out that the variability is not really different in the real world for chromogenic assays. We are moving toward using chromogenic assay because they simplify measuring factor VIII, particularly for extended half-life, and we will need to have this test for measuring factor VIII in presence of Hemlibra. We are not solving this way another problem, which is the one of inter-assay variability. And with this one, I'll give back control to Lina.
Thank you very much to all of our speakers. That was great. We do have a couple of questions that we'll address, and to our remaining participants, please feel free to use the question and answer or the chat function to ask any questions. The first one we have here, I'm going to address to Dr. Legal, and it's regarding the SSPE study. And if you can comment on whether we know the differences of recurrent VTE rates depending on whether the SSPE was provoked or unprovoked.
I don't think I can. I don't remember out of my, it's something certainly interesting, and I'm pretty sure we did capture the data, but I don't know the results. Sorry.
That's okay. Perhaps in a subgroup analysis we can see that. All right. And our next question is for Dr. Iorio, and it's related to the BT200 increased platelet count, while at the same time increasing the level of the gain of function for von Willebrand factor, which supposedly binds to platelet causing platelet cross-linking, resulting in increased clearance. If you could clarify that.
I'll try. I'm quite intimidated answering to Manchu Poon on von Willebrand because he knows much more than I do. The way this was explained in the presentation is that the BT200 by decreasing the clearance of the antigen of von Willebrand, at the same time alter the ratio of different forms of von Willebrand, and it possibly also diminishes the affinity for platelets. Now, my knowledge was that the binding to platelets is not on the A domain where the aptamer binds, which I think is what triggered your question, Manchu. But besides being confirmed by data, the explanatory hypothesis that was proposed is that again, it changes the relative proportion of different conformation of von Willebrand, and it hinders the binding to platelets itself.
Great, thank you. I hope that helped to clarify the question. If it didn't, we do have the ability to allow you to speak. So if that's something you'd like, we can certainly do that, just to ask some more questions. And if other people have questions that they prefer to ask verbally rather than type in the chat or the Q&A, please let us know. All right. Perhaps I'll just ask my colleagues related to the studies that I presented, in particular the distal DVT study, if that information on a change in duration of rivaroxaban, does that sway your treatment pattern for distal DVT? Mark, of course, I know you deal with the pediatric population and may not see a lot of this, but for Dr. Legal and Dr. Iorio, is this information that you think will change your practice when you're managing patients with distal DVT?
I can say that it's certainly difficult to ignore. So it's a study we are considering, at least here at MAC. If I can, I'd like to ask you back if you would be ready to change the standard treatment in both males and females, because the finding you showed are very puzzling on not having not a blink of a difference in males. Mm-hmm. And even if the study is not huge and the events are not many, it's unlikely to be by chance. So do we need more data in males? Is there any plan of accruing those data, or are we ready to change if we change? And I leave this to Gregoire. Both in males and females, or in females only for now?
Yeah, well, we start seeing these differences, right? I was seeing today some differences in risk of bleeding as well. So certainly there is more to explore there when we typically didn't see that many differences in the past, right? Yeah, I think we likely need more data before, as you said, it's starting to do this kind of implement this kind of differential management in practice, but it's certainly very interesting to see.
Yeah, I think the other thing to keep in mind is the study was stopped because of poor recruitment. And so these are challenging cases to find a large number of, so not quite as challenging as pregnant women with suspected PE, of course, but so I think sometimes our ability to do further studies are limited. One of the things that I think is interesting is the number of people who had muscular vein clot. 2/3 of the population. And typically when I see those patients, I usually don't anticoagulate those. I usually do anti-inflammatories and serial ultrasound on those patients. So I'd kind of also like to know what the distribution of recurrent clots was in that group compared to those with the ones where I might consider treatment, the anterior tibial vein or posterior tibial veins, that sort of thing.
Yeah, and maybe, you know, when you don't treat, Lena, you do serial ultrasounds, right? To your monitor. So maybe, you know, if you treat, you need to treat 3 months so that it's really treated. And if you stop halfway through, maybe then you would need to monitor as well, right? And to see. So it's, yeah, difficult to know how to sort it out.
Definitely. It's good to know, though, that extending therapy didn't result in any bleeding concerns. So I think that's an important consideration, that it was a safe decision to do that. So if that helps to factor into anybody's decision-making process when you're discussing that with patients. So that's great. I'm not seeing any other questions from our audience members. So if our panelists have questions for each other, or if you'd like to ask any questions, Mark or Alfonso, I'm not sure if you have any questions for each other. But also for our participants, the link for the evaluation is posted in the chat box, so you can click on that, and that will allow you to claim your credits for accreditation as well. All right. If there are, yeah, go ahead.
Sorry, no, I wanted to offer Mark a chance of he did a very thorough discussion of the Pednet data, but I wonder if there's any specific message that may apply to Canada around following the joint disease of our peds, considering our own way of putting them on prophy that is slightly different from the one used in Europe. So I don't know if there's any comment you want to make relative to Canada.
I think it really speaks to the importance of having good physiotherapy, which in some of our centers, it's not a problem, but in other centers, it's a real struggle to not just have physiotherapists who are excellent at joint assessment, but also joint ultrasound, which is a very specific skill that not every physiotherapist can do, but is something that I think we need to, as a community, continue to push, because it does show us that it can be a very useful tool, and having people who can do those assessments in a formal way. And yeah, you're right. I mean, we've approached prophylaxis maybe slightly different here, but it would be interesting to see if we're seeing the same outcomes. And I know there's been a few publications that have shown that we are still seeing that early joint damage as these kids age into the early adulthood. And I think for my colleagues who see more adults than I do, I think it's, hearing that a lot of prophylaxis is stopped as these boys get into their 20s and into their 30s, that maybe this is another, I don't know if it's a carrot or stick to really show that, there is an importance to doing this type of treatment, acknowledging that it can be burdensome.
Thank you.
Great, thank you. So I'm not seeing other questions from our participants, so I would like to thank our speakers and our participants for joining us this evening. I hope you did take away some great information. I learned a lot from my colleagues, so many thanks to all of you, and I wish you all a good evening. Thanks again.